We're going to go ahead and get started this morning. First of all, I want to welcome everybody to the Coalition of Orange County Community Health Centers Coffee Connections event. It's wonderful to have you all here today. My name is Ryan Yamamoto. I'm the Chief Operating Officer with the Coalition of Orange County Community Health Centers, and I'm honored to host today's important dialogue on advancing community health, advocacy, and power building principles. Today, we represent over 20 community health centers and one community-based organization, of which our health centers operate over 80 locations and provide about 1 million encounters per year and serve close to about 300,000 patients. I'd like to start off today by thanking those that are really making today possible. First of all, I'd like to thank all of our attendees. Thank you for showing up, for your commitment to equity, and for engaging in this important conversation. Also to our speakers, thank you for sharing your expertise and vital perspectives on this vital topic. To our community health center members and community partners, your dedication to our communities and to work that you do is really the heart of everything that we have in our communities. And lastly, I really want to give a great welcome to our students and emerging leaders in the rooms. You are really the energy and passion that you all bring really hopes to shape the future of healthcare as we know it. Sorry. So for today's session and purpose, our Coffee Connections or events are really designed to be more than just conversations. They're spaces we can all come together and work as a community to dive into timely health topics, share ideas, spark meaningful action, and it's also a place to space to connect with others in the room and build relationships as you have already done. So that's one of the key things we've built into our Coffee Connection is really about the networking piece. So I really want to stress, especially for our students and new leaders, to connect with the people around you. If you don't mind, I would even say try not to sit with each other. If you can find another open seat at another table, please feel free to move. And just so you expose yourself to the different people in the community and in this space, so you get a better understanding of who's in the room and who you can share that information with. Today's session really does focus on a critical and timely issue, the intersection of policy, advocacy, and power building with the pending state and federal budget decisions and the health implications that it has for all of our communities. Understanding how health decisions are made and how we can influence them is a key to advancing equity and access in healthcare together. And we'll break down the budget process, explore practical strategies for advocacy, and hear directly from leaders in the communities that are actually shaping policy and driving change on the ground. This session is really about equipping ourselves with knowledge, tools, and for each other to become more effective advocates in the community and to impact health. So today we're going to begin with an opening presentation by Chris Haney, the Executive Director of the California Budget and Policy Center, who's been in this role since 2012. I'll keep it short there. Then we'll also have us joined by Dr. Jeffrey Reynoso, who's a former regional director with the U.S. Department of Health and Human Services, Region 9. He'll introduce principles of power building and really facilitate a group dynamic process and activity that will focus on budget advocacy. And then lastly, we'll end the program with an expert panel discussion that'll build on the themes of the day, bring multiple perspectives to the tables, and give you a better sense of how this actually looks like, what it looks like on the ground, followed by a quick Q&A session as well. So before we begin, a few reminders today. Please note that today this event is being recorded, and it will be available on the Coalition OC's YouTube channel. And for the most part, it's really there so others can benefit and share the insights for today. Together, we want to commit to fostering a space where everyone feels welcome. And we also want to create a respectful place. So please keep our conversation professional and respectful, and we'll make sure that we have a great time while we're doing this. There is going to be a Q&A session as well. And so with that, please raise your hand and we will have microphone runners that will come directly to you again to make sure that we're able to capture your comments and your questions to make sure it's also recorded. And then lastly, we really love your feedback. So on the back of the tabletop, you will definitely see 2 QR codes there. So one of them actually is for you to share your comments and thoughts. We really do take to heart your comments and questions, as we want to use that to help inform our future Coffee Connections events. So as we begin today's conversation, advancing community health through advocacy and power building, we do know something, that the stakes have never been so higher for our communities that we serve. We are in a moment where our federal and state budget decisions are not only deeply intertwined, but collectively threaten to dismantle decades of progress in health equity and access. At the federal level, we have proposals that will slash over $800 billion from the Medicaid and the ACA through job loss penalties, reduced provider payments, and new barriers to care for immigrant communities. Here in California, we're also facing a $12 billion budget deficit and confronting proposals to eliminate prospective payment systems, payments for FQHCs, cut critical wraparound services, strip full-scope dental and acupunctural coverage. And really, at the end of the day, the other threat is to really eliminate a lot of the financial opportunities we've had that were made through Prop 56 and Prop 35, as those tax revenues have been pulled to support the deficit at the state level. At its core, this isn't just about numbers. It's about the stability of our healthcare system and the ripple effects when it's undermined. It means care becomes out of reach for families, delivery systems face closure, and critical services that our communities rely on begin to disappear. But we also know this: none of it is happening in a vacuum. You, our health centers, community partners, community members, professionals, and advocates are the ones that hold this system together. We build trust together, we drive innovation, and just for showing up every day in the service of equity and community health. So today is about two things: getting clear on what's coming and what the May revise and the One Big Beautiful Bill actually means for our work on the ground. Getting ready to respond, not as individuals, but as a collective, as a whole, to advocate with strategy, shared values, and collective power. Because when we talk about healthy communities, we know they begin with informed, connected, and activated people. With that, we'll start with our keynote to really demystify the state budget process and bring us up to speed on both state and federal developments. And to do this, we're going to launch with Chris Haney, Executive Director of the California Budget and Policy Center. I do have more to say about Chris, but he asked me not to say a lot about him. He makes it sound like an obituary, so I'm going to call you out, Chris. But again, an individual that is very well versed in this, has also served in DC as well, and actually has a PhD in political science from Claremont Graduate University, a poli-sci degree also from College of Idaho. Please join me in welcoming Chris Haney.
Good morning, everyone. It's a real delight to be with you here in your community this morning in this beautiful building. My organization is based in Sacramento. We have people across the state in various ways. Our mission is to improve outcomes for people in California, particularly low-income communities and people of color, those who've been left out of our state's success, and to do that through public policy, research, analysis, and advocacy. We also do that by trying to be in partnership with community, particularly with grassroots organizing and power building organizations that do the work on the ground to make sure that public policy changes that we think are good ideas can happen, and that we hear from them about what good ideas they think need to happen, and that we can do our part in Sacramento to try and make that happen there. I will say that I wish I was coming to speak to you today with better news about what's happening at the federal and the state level. But I'm going to share the news that's there, and I hope that whatever emotions or reactions that bring up for you, that at the end of the day, whether that's disappointment or outrage or anger or all of the above, that it also comes with a sense of needing to take action, to use your voice. And I know Jeffrey is going to talk about ways to do that, and I'll touch on a couple briefly. Hopefully that'll be a segue to that. Because we need your voices right now more than ever in order to make sure that the systems you're all trying to ensure that are delivered to the communities we're trying to serve are protected and invested in, and that we mitigate whatever damage that potential cuts that might happen has on your communities. So I'm going to walk through some of the federal and state budget proposals and the threats, and I'll be touching upon timeline and process, various things along the way. I'm going to provide an overview of the federal budget, timelines and process quickly, highlight the importance of federal funding to California, which I don't think will be news to anyone in this room, outline the current federal threats and what's happening right now, outline current state budget proposals, and then give you a quick snapshot of some advocacy opportunities. So I want to start, though, just with a couple of process considerations, because trying to understand how to create a state budget right now is a little bit of an adventure because the federal process and timelines don't align with the state. So the state budget process has very strict guidelines and deadlines that are in the state constitution or are in state law. The governor has to release a budget proposal for the next fiscal year, which starts July 1st. He has to start that in January. The legislature then deliberates for several months. The governor gets a second bite of the apple, has to put out the May revision by May 14th. So that's just happened in the last month. And then the legislature has to deliberate all over again to align their different bills and budget proposals into one budget package that they have to complete and send to the governor by June 15th. The governor then has to sign that into law to start the fiscal year by July 1st. Very strict deadlines. They have to meet them. There are incentives to meet them, like the legislature doesn't get their pay and per diem if they go over the June 15th date, for instance. So lo and behold, they tend to get the budget done by June 15th. But these are very strict deadlines that are in state law. That is not the case at the federal level. And one of the things I just want to say, there's a lot of words on some of these slides. It's intended to be a leave behind for you. I'm just going to walk through the big highlights. But the first thing I want to say is that the federal budget is on a different fiscal year, starting October 1st of each year. And other than that, there are no hard deadlines that any budget process at the federal level has to meet, like what we see at the state. And so the places that you're hearing about this year where there are budget threats in some form or another is you're hearing about executive actions where the Trump administration is trying to withhold funding or pull back on funding. That doesn't need congressional action, and so there's ways that you're all hearing and seeing that happening. There's a debt ceiling process where later this summer they have to raise the debt ceiling so they don't default on the debt we owe to countries around the country, which would create a global economic crisis because of the size of our country and the size of that debt. They could try to package together budget cuts as part of a debt ceiling package, although they're most likely going to probably put that in the budget reconciliation process I'm going to talk about in a few minutes. There's normal budget appropriations, the normal process at the federal level that looks like what's at the state level. That takes 60 votes in the US Senate, so they're probably not going to use that as a way to get anything done. The Trump administration has made proposed cuts, but those are very unlikely to attract Democratic votes in the Senate to overcome the filibuster. So they're mostly just proposals that won't go anywhere, and most presidents have not been able to enact a normal federal budget for at least a decade because of the split in Congress. Then there's budget reconciliation, and I'm going to talk more about that in a minute because that's the sort of big wonky elephant in the room where we're dealing with potential federal cuts. And lastly, the other place you could see things come up this year is through something called the Farm Bill, which has to be renewed. And the Farm Bill is has within it is where we fund SNAP or food assistance or what we call CalFresh here in California. And so that has to be re-upped, and changes they don't get done through budget reconciliation or otherwise could happen there. So these are all things we have to watch for over the course of the year. And other than things that have to get done in a normal course of a fiscal year, there isn't the set of deadlines. So that means state leaders are having to enact a state budget in the next couple of weeks, not knowing what's coming at the federal level. And so I just want to say that level of uncertainty makes the state budget part a little harder to manage. So let's talk just about what the federal funding looks like, and it's important to California. If you look at the current year budget, the proposed budget, federal funds make up about $170 billion of all the funds at the state level. And the vast majority of those funds are actually for Medi-Cal. or our state's Medicaid system. So this, for the next year, $112 billion of that $170 billion comes in just for Medi-Cal to provide health insurance to low-income folks and people with disabilities. So the Medi-Cal piece of this is the big deal. It's not the only deal, but it's the one we're most concerned about because potential cuts or changes in that program can both dramatically reduce the number of people who are eligible for Medi-Cal, which means they won't be getting their health care, of course, and it destabilizes their lives. But it also can result in big cuts to the state budget, which means state leaders may then have to make some of their own hard decisions about those programs and the state aspects of them. It's not the only place where we're worried about cuts. The other major place is the one I mentioned, which is SNAP or CalFresh, where over 5 million households in the state are actually eligible for the food assistance program. It's all funded or almost all funded at the federal level. Traditionally been a federal program. The only funding the state pays for is a small percentage of administrative costs. So this is a place where if they make any changes, and I'll talk about some of those changes, there's both the potential loss of the grocery assistance and access to food, but there's also the state having to figure out how to deal with the potential cuts in funding and forcing the state to actually pay part of the bill. Of course, there's other areas, child care and development programs, housing and homelessness, K through 12, and the money that comes to cities, counties, school districts. But the budget reconciliation process I'm going to talk about, mostly the big threats are in that Medi-Cal and SNAP space. And I'll say more about that now. So the current federal threats, the way this all looks is there's 3 big categories of what's happening. All of this is being done. All the proposals are about a massive tax cut that's primarily for high-income households and for corporations. The way that they're trying to offset some of that cost is through cuts to Medicaid or Medi-Cal and to food assistance. And then there's also big additional funding at a scale that hasn't been seen previously in terms of funding for the agencies at the federal level that would handle the immigrant detention, deportations, and related efforts around the Trump administration's efforts, anti-immigration efforts. So that's like what the whole package is that they're trying to get through, and that's where this reconciliation process comes into play. You don't really need to understand why they call it budget reconciliation other than to understand it's just a separate fast track process by which they can get budget changes through. And the reason it's a fast track process is they don't need 60 votes in the Senate, which is the number of votes you need to overcome the filibuster. In the current composition of Congress or the US Senate, 60 votes would require Democratic votes. So the Trump administration and Republicans in Congress, which have a majority in the Senate, would prefer to use the reconciliation process where they only need 51 votes. So that's why we're talking about this process. That process has some much more strict requirements about what they can and they can't do. And one of the things to understand is we're only partway through the process, which means they haven't gotten this done yet, no matter how much you've sort of seen in the news that makes it feel like a done deal. And that's why we all have work to do to try to stop some of the bad stuff from happening. The first step was they had to pass a budget resolution that just says, here's the framework of stuff, tax cuts, domestic program cuts, money for anti-immigration efforts. That was what they did back in April in both houses. Then the House committee met and came out with their own version of a reconciliation bill, and they got that passed on May 22nd. So now that kicks over to the US Senate, which kind of goes through its own process, and they're starting that process this week, and they're intending to more publicly vet their bill the week of July 9th, so next week. If the Senate gets their bill done, which they're saying they want to have done by later this month or early July, if the House passes the same bill without any changes, it can just be done and it goes to the president. But that's probably not how it's going to happen, and the House isn't going to agree with the Senate, so they then have to work together to align the bills, get one bill in place, both take votes, and then if they do that, it goes to the president. So just want you to understand that they're only halfway through this process, and this could take some time. And the more it takes more time, the more they're struggling to actually get the consensus that they need. And that's all good. right, for mitigating the potential damage and the cuts should do. So the more you hear things like block and delay, that's actually good news, at least in the context of the space or the landscape that we're in right now. Right now, the U.S. Senate's deliberations plan is they're saying they want to get their bill done by July 4th. They have to pass their reconciliation bill and then hope that the House will just take the Senate bill and say that's good. Like I said, that may not happen. That timeline may prove challenging, and this could get delayed through the summer. And the sort of backup plan they have is to try to get this done before they go on an August recess, but we'll see if that happens. So what's in that reconciliation bill, at least the House version? We haven't seen the Senate side. They work a lot more in quiet behind closed doors. The House works much more publicly. So the big picture there is that there's over $700 billion in cuts to Medicaid, plus other reductions that best estimates we have are that about 4 million Californians would be at risk of losing their health care coverage. I'll say more about the details there in a second. There's at least $300 billion in cuts to SNAP or CalFresh. That's about 900,000 Californians out of the 5 million who get it now who might be at risk of losing their grocery and food assistance. And all of that helps offset the cost of providing over $4 trillion in tax cuts for the wealthy and corporations. And I would note there's another sort of negative part there where you'll hear that those tax cuts also include an expansion of the child tax credit, which is a tax credit that goes to families with kids and has generally been a good anti-poverty mechanism. But the provisions for expanding that child tax credit exclude primarily low-income and immigrant children in a purposeful way, and primarily the dollars go to sort of middle income and upper income folks. So the expansion looks kind of like a good thing on paper, but it has some negative consequences in terms of who isn't covered. So let's talk a little bit about the specific proposals, particularly to Medi-Cal. There's imposing additional work requirements to make adults show proof that they're working or looking for work or participating in job train programs. There's a potential penalty to the state of California for using any of its own state dollars to fund an expansion of Medi-Cal to Californians who are undocumented. So if the state sends any dollars there, the federal reimbursement rate drops from 90% to 80%. Remember, the federal dollars coming in are about $112 billion this next year. So a 10% cut in the funding that comes in from the federal government could mean $7, $8, $9, $10 billion, depending on how it's structured. There's increasing eligibility check for adults in the ACA expansion population, so making folks have to conduct checks every 6 months instead of 12 months. This is just a sort of red tape administrative hassle that just results in people accidentally getting kicked off because they didn't realize they had to go through the check process one more time a year. There's then prohibiting coverage of gender-affirming care, defunding providers that offer abortion services, a major threat to Planned Parenthood, of course, and eliminating eligibility of certain immigrant populations for the marketplace subsidies in Medicare. So that's the whole package of what are in the cuts, unfortunately, on the Medi-Cal front. On the SNAP front, the biggest threat in terms of what they're proposing is, for the first time in the history of the program, to make the states cover a share of the cost. And California, because of the way they've structured this proposal, would go from a small amount of funding going to administrating the program to shifting to have it to cover 25% of the cost if they want to keep the program at the same level. So that's a $3 to $4 billion hit a year that the state would have to figure out how to cover. There's also harsh time limits, preventing immigrants who are not naturalized citizens or have a green card, permanently freezing the thrifty food plan that was expanded in recent years, and putting pressure on other programs like summer EBT, food banks, and the like. So also a set of cuts here. This is all in the sort of $1 billion they're trying to do to offset the costs of the tax cuts. So I just want to say, like, all of that sounds really horrible, and remember it's still in proposal form. So it's not a done deal. It's not a foregone conclusion. If any of this were to take effect, it obviously has a really negative impact on Californians and their access to food, their access to health care, destabilizes their lives in ways you all understand very well. But it's also very destabilizing to the state government, where the potential loss of billions of dollars a year means state leaders would have to make some really hard decisions about some of these same programs in terms of the state's administration plus other programs. And the reason we need money from the federal government is because the scale is just so much larger than for an individual state. And there's just no way the state is going to be able to backfill every dollar that might potentially be lost at the federal level. And that means state leaders would end up having to make some very hard decisions about what gets maintained, what gets protected. Which brings me to talking about the California budget. So all of that stuff happened, and is still in progress at the federal level and has months still to go. But state leaders have to craft and finalize the state budget. So the governor came out with the May revision. The legislature's debating what to do about that as we speak. They'll probably get their work done by early June. And so what we're dealing with right now is just what's in the governor's proposals. I want to reinforce here again, proposals. The legislature's already pushing back very hard about what's in some of the governor's package. But I want to say there's some very disappointing news of just about how the governor is responding so far. So big context is the state's facing a shortfall. Back in January when the governor released his budget, the budget was sort of flat after a couple years of shortfall. But now, because of increasing uncertainty in the economy, largely due to tariff policies, which are harming commerce and also resulting in inflation threats, there's now a economic outlook that means the revenue coming into the state is likely also lower, so that's resulting in a shortfall. Plus there's some spending that's higher than expected, particularly in the Medi-Cal arena, which is not a great time for that news to be dropping, because that means state leaders are then feeling like they have to address cost overruns in an area where we're already facing threats at the federal level. The governor's proposal would still leave $16 billion in reserves. So I just want you to sort of think about, okay, there's about a $7.5 billion shortfall, but there's $16 billion in reserves, particularly in the context of the cuts that are being proposed. There's no new revenues or taxes. And then there's $5 billion in cuts that the governor's proposing to help cover the shortfall. And unfortunately, the governor's proposal has most of those cuts, that's $5 billion, coming in the health and the human services arena, primarily targeting undocumented adults, ages 18 and over, foster youth, seniors, people with disabilities, healthcare for LGBTQ plus folks, and I'll say more about the specifics there, and doesn't, as an alternative, try to raise any additional revenue or use reserves. The specific threats that are there, so there's a whole set of proposals in the governor's budget that target undocumented adults. So there's a freeze on being able to enroll for adults. There's a new $100 monthly Medi-Cal premium for adults that is sort of unprecedented in the sense of making people have a premium or a copay to access Medi-Cal. There's elimination of long-term care coverage for adults, elimination of full-scope dental coverage, elimination of in-home support services, and then reduced funding for community clinics, FQHCs, and rural health clinics. So that's all stuff that's in the governor's proposal that has deep implications for undocumented adults. And then there's a whole set of other cuts that are things like, that are more broad Medi-Cal, like reinstating Medi-Cal asset limits. So if people have a second car or a couple $1,000s in savings, you're kicking them off. We fought for years to get this harmful provision pulled out. The governor's proposing to put it back in. Additional cuts to IHSS, ending coverage for acupuncture and GLP-1 drugs, elimination of over-the-counter drug coverage, and various other sorts of things that are just sort of cost coverage sorts of issues in Medi-Cal, but that are harmful for all the communities you're trying to serve. So just want to note that, remember, those are proposals. I don't think the legislature is happy with the governor's proposal, and unlike at the congressional level, there's actually significant pushback already happening, and I think the legislature likely is going to win a lot of those battles. So I don't want you to think of these as foregone conclusions, but it's not a good sign that the governor is proposing these kinds of cuts while we're anticipating worse news coming at the federal level. We would prefer that he was holding the line and saying we're going to push back at that in an effort to try to protect these programs and invest in them if we can in order to backfill some of what might be lost at the federal level. I'm not going to say too much here, but just I want to say there's a series of other things that are about Prop 56, ending supplemental payments, suspending loan repayment programs. The governor's not been happy at all that he wasn't able to use Prop 656 funding for general fund purposes and was forced by voters to put that funding back into reimbursing providers where it was intended. And so there's some other sort of changes and things that he's put into his proposal there. There are lots of opportunities for advocacy here, so I just want to say that this is where we need your voices, and this isn't going to be Powerbuilding. That's what you're going to get from Dr. Reynoso, but it is sort of traditional advocacy where we need your help. We obviously need help with Republican members of Congress because making that a tough vote whenever the comes back to the House is something, you know, that we need to make it very clear to folks that this is about people losing their health care and people losing their groceries and their food assistance in order to give tax cuts to high-income folks and corporations. That same advocacy work needs to be done with the state legislature because the state legislature itself needs to be doing that advocacy at the federal level. So you can do advocacy with state legislative leaders, not just about the state budget, but you can do it also in terms of pushing them to use their voices as people with bully pulpits to take action, to contact their members of Congress. And then there's the work, of course, you can do at the state level to try to make sure the state's response is aggressive, is defensive of these programs, and is trying to protect and invest in them as much as possible. And this is all just very traditional advocacy, contacting your legislators, contacting your members of Congress, having your voice heard, but it's more important now than ever, and that can be done social media, it can be done email, it can be done as a phone call. If you come to Sacramento, you can certainly try to meet with folks, or if you're in DC, there's certainly ways to do that as well. I do want to say I hope you'll use this as a resource before I take a few minutes of Q&A here. We have on our website a federal page that has a whole set of resources that include congressional district level information on the people who are eligible for the programs I've been talking about, the potential of folks who could be cut, and we'll keep updating that with the data as we're getting in from federal partners and national partners. And we also, if you just need information about how the state and the federal budget process work, we have a Budget Academy up on our website where you can access lots of technical information about the process, the words, the definitions, and all of that as an ongoing source of help. So, sorry, let me see if I can clear that. Why just get rid of it? Oh, sorry, thanks. All right, so I'm going to stop there. I'm going to try to anyway. Anyway, the last slide just says thank you. So thank you all for the chance to bring you some sobering news. I hope it also fires you up to be able to do the advocacy work that is needed and to do the power building work that Jeffrey is going to talk about next. But I know we've got time for a little bit of Q&A and answer your questions as best I can as long as you'll indulge me. Thanks.
Don't need these services, it's insanity. So I'm angry, and I hope everybody's angry, and I hope everybody gets off our complacent places. I'm not saying anyone's complacent, it's just overwhelming.
It's overwhelming, and but it's not done. And I think we need the people's voices we need the most are the people who would be affected. It just isn't as effective for someone like me to contact David Dalladeo or, Representative Kim. They need to hear from the folks who are their constituents. They hear from experts and think tank people all the time. There are ways that, and we don't have to start from scratch. There are existing coalitions that are doing this work. There's a Fight for Our Health coalition at the state level that's made up of a huge array of organizations, and they're doing regional and local actions. People can access those. There's a similar coalition that's doing the work on the food assistance. There is a community organizing and power building network around the state called We Are California that's doing organizing of the affected communities and doing actions here in your region. For instance, I think they're being led by Orange County Action or OC Action. So there's ways to access the things that are already happening. It's not like you have to start from scratch in all of the instances in order to take some action.
Hi, Dr. Jaley. Good to see you. So I'm a doctor, and I know a little bit about policy stuff. knowing that things are in the Senate right now, will you remind us again what the Byrd rule is, and to what extent you think that that can help slow things down in terms of this current process? And yes, I agree with continuing to put pressure on our electeds. In many ways, this is probably the only time I ever wear a white coat is when I go visit with electeds.
Yeah, thank you for asking about the Byrd rule. That's actually something that's actually the process they're going through in the Senate right now. It's named after a former senator from West Virginia, Robert Byrd. And it's back when they put the budget reconciliation process in place. He created a set of rules to make sure that the budget reconciliation was more narrow than normal budget process. And the way that that happens is there are only three things you can do in a budget reconciliation package. You can change taxes in some raising or lower them. You can increase spending or decrease spending, and you can raise the debt limit, or you can do something with debt. What you can't do is enact a range of policies that that aren't being done for financial purposes. So there's really strict rules in there. So if what happens is they have this, it's really arcane, but there's a Senate parliamentarian who suddenly has a ton of power in the country, who has to determine whether some of the policy proposals in the federal package that the House put forward or that the Senate's considering, whether they're actually financially related or they're just being done for like other policy reasons or other policy incentives. So the parliamentarian is deliberating with Senate leaders and they're scraping the bill. Right? And this is a place where it's actually the process is designed to help the minority party protect certain things, and that the majority just can't do whatever it wants. And so the Byrd rule is a way that this process could scale back the cuts, and it can also delay the process. And it's why the Senate has so much more control in this instance, because the House eventually has to pass something that the Senate can get through the parliamentarian. Okay, great. I think we're going to stop and move on to the next section there. Didn't mean to end on the Senate parliamentarian, but that's what's going on right now. I hope you'll all take some time to take some action on this. Please contact my organization if you need some help. We do our best to say yes, and we're designed to be a budget and policy arm of organizations like yours that are out in the community. So please reach out to us, and we'll do what we can to help. Thank you.
All right. Well, thank you, Chris, for setting the stage and breaking down the complex realities of both the state and federal budget process. Your insights, I think, will help us understand it's not about just the numbers. It really is about the impact it has on our communities. Next, we'll hear from Dr. Jeffrey Reynoso, former regional director from the U.S. Department of Health and Human Services, Region 9, covering the Southwest and Pacific areas. Dr. Reynoso is a seasoned public health leader committed to advancing health equity and justice through health policy, system change. His career expands academia, government, and nonprofit organizations, at the local levels. Prior to his role as regional director, he served as executive director for Latino Coalition for Healthy California, a statewide organization that advocates for Latino health through grassroots leadership development, strategic communications, and public advocacy. Today, he's going to introduce to you some key principles of Powerbuilding and lead us in a group activity focused on budget advocacy. So with that, Dr. Reynoso, please come to the stage.
All right, good morning, everybody. My watch is telling me it's time to stand up, so if folks want to take like a few seconds to get up, move around, I think it's helpful I know the material can be a little bit dense, so it's helpful to get a stretch break in here. So I'll start with kind of a story of how I got involved with policy advocacy. My background, I am a doctor, but not that type of doctor. I'm not a clinician. My training is in public health. And I started out my career at a community health center as a member of Ultimate Health Services up in. They have clinics here down in OC in LA County, as part of an AmeriCorps program and worked really closely with health educators. So have a huge appreciation for FQHCs, community health centers, a safety net. And after my master's program, I ended up at a county health department in San Diego County, worked for the director's office there. So my background is very much in the community. And it wasn't until the first Trump administration that I was working for a health plan, doing what I thought was pretty impactful work around addressing food insecurity with our members, primarily Medicaid, Medi-Cal members here in Southern California region. And I started getting these feelings of frustration of, seeing the attacks at that time of the Affordable Care Act on Medicaid, all these programs that I knew were really impactful and life-changing for the communities that I cared about. So that's what got me to Latino Coalition for Healthy California. So I had the honor to serve up in Sacramento. I was executive director for 5.5 or so years during the first Trump administration, transition into the Biden administration, and ultimately joined the Biden administration as regional director of health of the Department of Health and Human Services for Southwest and Pacific. So I share that story because you kind of don't know where your career may end up. And if I hope to, especially for some of the students here, I really do think that public health, health advocacy is where it's at. I mean, there's no greater, I think, calling than serving the most marginalized in our society, in our state here in California. So with that, a little bit of context setting and Chris did a great job. And this is not great news, but the Department of Health and Human Services, our public health and healthcare systems are facing their greatest threat in probably its history. I think being someone who was at the department and was a senior leader at HHS and seeing some of the threats and the just dismantling of our department and the programs that serve primarily low-income Americans and the most marginalized, it's really heartbreaking. So I really resonate with those of you that express anger, frustration, fear. Just as an example, when Secretary RFK Jr. put out his new restructuring of the department, after the fork in the road, which was kind of that voluntary resignation for HHS employees, I think it was late March, they announced restructuring, and it was called reduction in force. So that was an additional 10,000 or so employees. My former office of HHS Region 9, we were up in San Francisco, over 300 employees, just completely cut. No really thinking of strategy of the purposes of the regional offices and how we were developed and created to be closer to the region and community. And so, I think it's a tough time right now. I'm still in touch on the daily with my former career civil servants that signed up to serve in government service because they care about the programs, regardless of political party, regardless of administration. That being said, I think the pace in the beginning felt it felt kind of new for us, right? I think that's for many of us, and I'm sure you all share kind of that feeling of not knowing what to do. There has been a slowing down, I think, of some of the attacks and a rolling back. Some of these things are in the courts. 20 Democratic attorney generals are fighting some of the cuts, primarily at CDC and NIH. Some of the decisions that were made early on around cutting certain programs, like the Women's Health Initiative, they changed their minds and rolled them back. So kind of the Dojification of HHS, a lot of it has happened, is going to happen, but some of it has rolled back because of the media, of people like raising their voices. And so we're going to talk more about how to fight back in the current environment. So if anyone's keeping track, today's 135 of Trump 2.0, and Stat News has a pretty good day-by-day account. And I think this is instructive because, we get all of these news alerts all the time about the latest threat to public health and healthcare. But they do a really good job of kind of cataloging all of the day-by-day changes at the department. So if anyone's interested in any particular provision, I really recommend this resource. But I was called here today, or asked to come out of my sabbatical a little bit and speak to you all. It's always great being back in Orange County to talk about some of the principles of power building. So like any recovering academic, I'll start with some theoretical frameworks around social determinants of health and health equity, and then we'll get to more of the practice-based portion of the session. You heard from Chris some opportunities for advocacy, and we'll hopefully have a pretty engaging exercise for y'all to participate in action on what you all are going to do when you get back to your day jobs or back to your communities, and how you can make a difference in fighting back. So a couple of frameworks, and many of these frameworks were established more from the public health science and research. Many of you have heard the word social determinants of health. There's some really great frameworks out there that date back to the 90s and even sooner than that in the literature. This is an image of the CDC, Healthy People 2030. So social determinants of health really describing what are the non-medical factors that impact the health and the morbidity and mortality outcomes of particular populations. So things that you all know, right? Access to safe neighborhoods, access to food, healthy foods that are affordable, and the ability to have a good paying job. And as these frameworks have evolved, there have also been frameworks that have talked about more specifically the why. Why do certain communities versus others have access to resources versus not? So frameworks like Krieger's eco-social theory, I think I took 2 entire graduate doctoral level courses on just understanding this one theory, by the way. So a lot of these frameworks are instructive, but from a public health practitioner's perspective, the frameworks that I find most helpful are those that were developed for action, right? So we're going to spend a couple of minutes reviewing Barhigh's Reducing Health Inequities framework. But before we go there, a couple of just ground-setting definitions around, we talked about social determinants. Really, as we all know, are the conditions and the environments in which people are born, they live, they learn, they work, they play, they worship, and age. Health equity is more of an aspirational type of definition, where what we mean by that is that everyone, regardless of your background or your status, has a fair and just opportunity to attain your fullest health potential, to be as healthy as possible. Structural changes are what are needed to achieve health equity and intervene on those social determinants of health. So if I can get a volunteer, can someone actually read the structural change definition for me? We're going to get into more of an interactive session. There we go. So can someone hand her a mic?
Structural change is about the development, implementation, and protection of policies, practices, and systems change to support a culture of health. A culture in which all people have equal opportunities to make healthy choices, whatever their circumstances. The structures can be rules and regulations, institutional policies and priorities, cultural norms and values, and disparities in power and influence.
Great. So in this definition, I believe this one's from the Robert Wood Johnson Foundation. They have an entire culture of health initiative. So it's really naming what are the specific structures in our society that create the community conditions. And what is really important to highlight in this definition is they talk about power. And that's really going to be the focus of our talk here today. So can I get another volunteer for the next definition? Community power in the back.
Community power is the ability of communities most impacted by structural inequality to develop, sustain, and grow an organized base of people who act together through democratic structures to set agendas, shift public discourse, influence who makes decisions, and cultivates ongoing relationships, a mutual accountability with decision makers that change systems and advance health equality.
Great. So, what this definition is really getting at is in order to change those structures or those systems, there are decision makers, and building networks, building a base of like minded people in your community coming together to shift the narrative around a particular issue or a particular set of agendas is really how one shifts and is able to organize within the community in order to change those power structures. So with that, that leads us into that final definition. So community power building is a set of strategies used by communities most impacted by structural inequity to develop, sustain, and grow an organized base of people who act together through democratic structures to set agendas, shift that public discourse, influence who makes decisions, and cultivate ongoing relationships of mutual accountability with decision makers that change systems and advance health equity. So with that, the Bar-High framework. So this framework was developed, I forget the exact date, but around 2010 or so. All of the Bay Area health departments came together to really map out the ecosystem of players that ultimately have an impact on downstream mortality, life expectancy for different populations. And it's really trying to highlight what are the types of interventions that are needed along the continuum, what they call current or downstream public health practice versus emerging or upstream public health practice. So I know it's a lot, so we're gonna take it in chunks. So on the right hand of the framework, and I believe everyone has it on their table, so I know this is hard to read. So if feel free to look at your tables as well. So downstream, how does someone become healthy or not healthy, right? And the types of interventions that many of us are familiar with, if we work at a community health center, at a hospital system, or I know there's some folks here from the county health department, the types of interventions are at that individual level, right? Think of someone with type 2 diabetes. You might prescribe, if you're a provider, metformin, right, to manage that diabetes. But we also know it's not just the medication. It takes, access to education, behavior change. I mentioned I started my career as a health educator, so I provided that one-on-one or group counseling with communities around healthy eating, active living. But here's the crutch of this, is that our patients are going back to their environment, to their community, right? So that's the kind of middle section of this framework. So the living conditions that we defined earlier as the social determinants of health. So what is the physical environment, the economic or work environment, the social environment, the service environment in which people live, work, and play? In order to change those community level conditions, at the bottom of the framework here, we need a different set of strategies, right? It's not going to be a medication, it's not going to be education, but it's going to require some community organizing, some base building, civic engagement, and we'll talk in a couple slides around what all of these things mean. Now, the most upstream of the framework and what ultimately is required to make an impact on what they call the root causes of health inequities are all of the isms, right, that we have in our society: classism, racism, xenophobia or anti-immigrant sentiment, sexism, transphobia, ageism. So all of these isms need to be shifted, or our understanding of them as a community, as a society. So what type of intervention do we propose for that? This is not part of their original framework. So like any former academic, I kind of added that narrative change. So really thinking about a narrative campaign, and we'll go through some examples of what's required to really change and shift the culture and our understanding of who's valued in our society and how we should invest in certain populations versus others. And there's this middle section here of the slide as well, these institutional inequities. So I'll just call out government agencies because I know we're going to talk about the budget. But what's really needed here in terms of strategies are those strategic partnerships, policy advocacy, and that ultimately then leads to systems change. So that was a lot, I realize. So some key takeaways from that framework. So go upstream to have population health impact. So working at an individual level, the types of strategies are going to be different than those upstream population health strategies. Number two, focus on policy and systems change interventions in order to address the root causes of those health inequities. So all of the isms on the left-hand side of the framework. And then finally, number three, consider creating strategic partnerships with organizations or initiatives that focus on power building. And there are many great organizations here in Orange County, across the state, that are building power towards protecting some of these attacks to our healthcare system, and we'll talk about some of those in a bit. So we have the framework now. We have some definitions. Now let's get into the playbook or the tactics of power building or policy and systems change for health equity. I was able to find this picture from a couple months ago. This is part of that Fight for Our Health, which is the national campaign that is being organized by a group called Protect Our Care, and they're partnering with state and local-based organizations, unions, ARP, other organizations, to really uplift the impact of the Medicaid cuts in local communities. So this is from just down the street in Anaheim at Representative Kim's office. So a couple of tactics, and we're not going to get into every single one of these tactics because I do want to get to the activity because I think it's going to be a lot of fun. But we talked about in Chris's presentation, when we think of policy advocacy, a lot of us point towards, legislative and policy advocacy. At least that's for me. That's what I think about. And it's going to hear, and I think a physician here talked about putting a white coat, talk to a legislator and having those one-on-one meetings, or going to a public comment hearing up in Sacramento here locally for a Board of Supervisor meeting. But there's other ways of advocacy. And, from my time at LCHC, one of the most impactful areas or tactics of advocacy was administrative advocacy. And what we mean by that is, once a law gets passed or a budget gets passed, it goes to the agency. So here in California, it'll go to the Department of Healthcare Services or the Department of Public Health, and they have some leeway and some power in how they implement the programs, whether it's with counties or CBOs or other organizations, health plans. So there's a lot of opportunity there for advocacy as well. But really what we're going to focus on for the power building section are on these other tactics of grassroots organizing, mobilization, everything from Capitol Days or joining a march. But what is more impactful from a longer term perspective is being engaged in a coalition. There's a strategy and there's a science to this. It may, democracy is messy, but there are organizations out there that have figured this out. They've gone through these cycles. They've gone through these administration changes, legislative changes, and they've figured out how to build coalition, how to build power to advance an agenda for the public. We will spend a little bit of time about media and public awareness. I talked about narrative change and how important it is to share our stories, right, as providers, as community members that understand our communities, so that we understand so that the decision makers understand what's going on the ground. So, quick case study before we get into our activity. It's a case study that we were engaged with when I was formerly in my former role at Latino Coalition for Healthy California, is the Health for All campaign. So that I chose this example because I know most of you know the expansion of Medi-Cal, regardless of status. It involved all of these tactics when we think about it, and it took a decade to implement. So from a legislative and policy advocacy perspective, there was a formal campaign called the Health for All campaign. We had two co-chairs, Health Access California and the California Immigrant Policy Center. There was a steering committee of which we were a part, and then there was a broader committee of local base building organizations across the state. But it also, that was kind of the outside strategy. It also took the inside strategy. We had our legislative champions in the Senate and the Assembly that helped us at every stage of those deadlines that we heard about for the budget and for the legislative process. We also had to understand from a coalition perspective and a campaign perspective that it wasn't going to happen all at once. So it took time. I think Health for All Kids started or was passed back in 2016, and then every 2 or so years we were able to expand to a broader population group, young adults, older adults, and then ultimately the full expansion. The administrative advocacy, that was equally important, particularly with the governor's office. We had strategic partnerships with both the Brown and then the Newsom administration. And with the Newsom administration in particular, they had, kind of this whole framework of how they governed of a California for all, and that kind of worked out, right? I mean, Health for All, California for all, alignment there. So trying to find those areas of commonality. But it also took grassroots organizing, mobilization, in particular with more of those moderate members in the Assembly and the Senate. So it took connecting with advocates on the ground. And if you talk with folks that were leading the coalition, leading the campaign, and also in the foundation sector, a moment of, I think of clarity for them with this particular campaign. It was a connection or a coalition of your health advocates, which I call more of the policy wonk type of folks that have been doing this work for a while, and the immigrant rights movement. And at that time, there was a strong dreamer movement going on. Some of our strongest voices on the campaign were pre-med students or pre-health students that were dreamers. And they were really able to kind of cut through the noise and create what I'm calling the narrative change aspect of the campaign. The California Endowment invested in the hashtag Health for All campaign. There were billboards up and down California. I think one of my favorite phrases from some of the billboards was, "I wasn't born in California, but California was born in me," and just like how powerful that is, right? And I think it really resonates with a lot of us that call it the state home. But it also took data and research, and I don't want to discount this because in those conversations, we need good data to show the impact of what an expansion would look like. When you talk about increasing access to primary care, you're also talking about reductions in ER visits, right? So those are conversations that needed to happen, but we needed researchers from UC Berkeley, UCLA, and other research centers that really helped us with the data aspects of that campaign. Okay, so now for the activity. So here are some examples or tools of Powerbuilding, and this is not an exhaustive list, but I pulled a few that kind of match with that Bar-High framework that I shared earlier. A landscape analysis, so really mapping out what the environment looks like with a particular issue, whether it's food insecurity, health access that you're facing or that you want to face in a particular community. Power analysis, which is what we're going to focus on for the activity. So mapping out who are the players that have different levels of power or are aligned with you or are less aligned with you in a particular issue. When it comes to base building, from a civic engagement perspective, there are groups that do integrated voter engagement. So really thinking about not just, a lot of traditional civic engagement has been, a couple weeks before election, we're gonna knock on your door, send you a flyer to get you out to vote. But there are groups in California that are thinking about integrated voter engagement. So how do we build, kind of a culture of civic engagement locally in our communities and involve folks that typically aren't tuned in to politics on a day-to-day basis. And then more upstream, you can get a little bit more researchy or technical with public opinion polling. It helps, kind of to get a sense of where the population or voters are at on a particular issue. And then we talked about narrative campaigns and how powerful that can be with folks sharing their stories and their experiences. So, okay, group exercise. This part one is the power analysis mapping. So you all are in your groups, in your tables, and if there's less people at your table, or if there are more folks at your table, I would recommend you jump over to another table so folks can kind of spread out. You have on your table a white notepad, and take out the paper with the grid. So the grid has pretty much a X and a Y axis, right? So going back to middle school or high school here. On the Y axis, the arrows state who's the most influential or powerful in terms of your objective. And on the bottom half of the paper, who's least influential or powerful. On the X axis, we're looking at who strongly opposes your position. And then on the right-hand side, who strongly supports your position. So identify a writer in your group, identify who's going to facilitate the conversation, and first, before you even get into writing who are the individuals or organizations that you're going to map out on the power analysis, let's get specific on what's going to be your goal. So this is what's called the change goal. And because we're doing budget, and it's budget season, right, up in Sacramento, an example would be we want to stop or we want to change a particular budget provision from being approved by the Assembly Budget Committee, right? You're going to write your change goal at the top of the paper, and then the sticky notes are where you're going to write who are going to be your campaign targets for that particular change goal. So this is where you can write a particular individual, maybe assembly member or a senator, but it can also be organizations. For example, Coalition of Orange County Health Centers. That would be an organization that you could potentially put on one of the sticky notes. And you're going to have a group discussion where you're going to think about, so this actor in this ecosystem, right? Policy advocacy ecosystem. Do they oppose my position? Do they not? Are they powerful? Are they not? When it comes to this particular change goal, and then you're going to map it out on the on your poster board. So we'll have a couple volunteers from the coalition. They're going to be going around to help everybody with this exercise, and we'll take about 10 or 15 minutes for this part one. And then we'll report back to the full group. Any questions? All right. Enjoy. Have fun. All right. How's it going? Who found this activity challenging? If it wasn't challenging, then you didn't do right. Okay. It's a tool and it's a muscle, building it out. And I know we didn't have a lot of time to really dig in, but I would like one group that feels like they got to a good place with their change goal and mapped out a good set of players that are involved. If you want to volunteer, if not, I'll volunteer. Oh, the group I was talking to in the back, I thought had a pretty good job. Did a pretty good job. So
we fear if it goes through, it will affect a lot of our members that we assist, especially now that even those who have minimal premiums when they have to go visit the doctors, it's already affecting them in that way. And then just the thought of them having to pay $100 to have coverage, it's just very bad idea. So for us, for our most influential or powerful, we thought of our clients and their stories, our navigators, specialists, Coloptima, they'll lose a lot of their members, community health centers, and representatives. For strongly oppose, the governor, MAGA, the wealthy, the uninformed, and social media, if they share fake news and things like that. Providers as well, we kind of had them on the 50-50 because we feel that some will oppose and some will strongly support us. And then for the support, we selected obviously the coalition, partners such as Latino Health Access and like the California Endowment. So this was for us.
Great. Let's give them a hand. It's really powerful when you're able to build partnerships with organizations or institutions that typically aren't on your side. I know, for example, Senator Josh Hawley, one of the main reasons why he's opposing the Medicaid cuts are so many rural hospitals have closed in his state. And so it really matters. So thank you all for being a guinea pig. I understand this is probably one of the first times that you all do this type of activity. And I hope it was productive. So before I close out, some final reflections for this session on principles of power building. Try to be as specific on the issue you're trying to address. So solving health disparities is probably a little bit too broad. Be more specific of, I'm going to prevent budget cuts. Still probably too broad, but I think y'all got the idea of the more specific you can be, the more actionable it can be, your tactics can be. Identify the best advocacy tactics and tools. So depending on your organization, your skill set, or the groups of organizations that you're working with, you may focus more on the base building, and there are organizations that do that. Or you may need a narrative change campaign, or sharing stories of those impacted or potentially impacted by these policy or budget changes. So really think about from that toolbox, right? What's the most important in that moment for that issue? Connect and build community power. And I can't stress this one enough. If we're individuals, it's really hard to affect policy and systems change. Nearly impossible. But it's building that connection, places like this, and partnering with organizations that you're really able to build power together. Resist and persist. So there are a lot of efforts happening, and during the first Trump administration, there were something like 50 votes to try to cut the Affordable Care Act. It never happened because of advocacy in locally with members of Congress, and we're in those fights right now with the budget, both at the federal level and the state level. So continue resisting, continue persisting. But this work is hard. As someone who has been kind of at that tip of the spear in the fight for 8+ years, I was towards the end of last year, around the election time, I was pretty burnt out. And I knew I needed, for my body, my mind, my soul, a time to rest and recharge. Is why I decided to take a sabbatical. It's okay to rest. You don't have to be out in front all the time. And these are long-term issues that are going to be there. So know when to take a step back and when to lead the charge. And then finally, remember or lead with your values. I think for many of us, we went into healthcare, public health for a reason. There are values that we care about, healthcare being a fundamental human right. I think all of us can agree that that's a value that we care about. Lean in on those values to get you through these tough moments. And, I'm in a lot of spaces and groups where the conversations are pretty dire, and it can be pretty depressing. So I try to remind myself and folks that I talk to, let's be joyful in the process. This doesn't have to be, this doesn't have to be power building is is at the end of the day about connecting with one another, connecting with like-minded folks to really change the world and make a better community, and at the end of the day, advance health equity. So remember to insert some joy in the process. Feel free to connect with me. I'll be around through the end of the day, and thanks for having me, for your participation.
Thank you, Dr. Reynoso, for sharing your insights and guiding us through those important principles of power building budget advocacy. And lastly, also thank you for your service. So we're going to continue our conversation with our expert panel, and really want to deepen the discussion and share their perspectives on advancing community health and using maybe some of these and demonstrating some of these community health, advancing community health and using some of the principles on power building and advocacy as they've done on the ground in real time. So with that, I want to invite our panelists to the stage, please.
W. Lee. I'm a family physician by training, and I'm the medical director at Integrated Health Partners of Southern California, and I'll get into the details of what that is a little bit later.
Hi, everyone. I'm Hilda Ortiz. I am the director of the Promotor Learning Institute at Latino Health Access, which is a local community-based organization.
Hi, good morning. My name is Dr. Reyes, CEO for Central City Community Health Center. I'm also a family medicine physician.
Good morning. My name is Phil Yeager. I am the CEO of Radiant Health Centers.
Thank you all for your introductions. I want to dive a little bit deeper right now and talk about some of the topics we've touched upon today to also hear more of your perspectives as well. So for our first question, and this is for all of our panelists, I think each of you brings a unique perspective to this work. How do you define power building in the context of your work? And if you could share a recent example of where you, as an organization, turn that definition to action, mobilizing power to create a tangible community change. So I'll start with Dr. Lee.
Great question. So as I noted, I'm a medical director at Integrated Health Partners of Southern California. We're a clinically integrated network. We've been around for about 10 years. And we were born out of the idea of power building, in essence. So this was 9 health centers, primarily in San Diego County, who decided that they want to do value-based care. And they all realized that they would not be able to do it on their own. And so they basically anteed up, kind of like a poker game, to sort of gamble on a future together. So fast forward 10 years, and we are leveraging data. We have engaged with leadership. We are moving successfully towards getting to 51% value-based care in our relationships with plans. And we're just shy of 400,000 mostly Medicaid recipients. So very difficult to do that with one health center, a lot easier to do it with 9. And so when we work together, we actually talk a lot about co-opetition. We're competing, but we're also cooperating with one another. And so I think that's been really instrumental. I think the breakthrough for us was really when people started to understand the power of data to show the impact of the work changes that are happening on the ground and how that can impact not just care gaps, but also patient satisfaction and experience in the health centers, and also the immense amount of growth that we've experienced over the last 10 years, particularly the last 3 years. We've grown quite a bit because of some of the quality measures and the interest from the plans to continue to bring patients to us.
Thank you, Dr. Lee. Hilda?
Yeah, so again, LHA is a local community-based organization. It was founded in 1993, also with the idea of power building. So I think our founder, America Bracho, and our founding promotoras went through a similar power analysis back in 1993, where really the big observation was that there where there was a large community with a long list of needs, but very little political influence, and so very little access to healthcare. A small amount of services, particularly in Spanish for the Latino community at the time. And so the organization was founded with that in mind. I think at the beginning it was called LHA, an Institute of Community Participation, or an Institute of Community Building. And really that has been the goal from the beginning. And the way that our founding members, our founding promotoras decided to implement this was by bringing in promotoras, by bringing in the community. It's impossible to do this and partner with community without the community being at the table. And so that has been the entire model. And I talk about this because that is the promotor model, the community-based promotor model is what we now implement 32 years later in all of our programs. We have a staff of over 100 people, 80 of them are promotores that are directly working on the ground, offering direct services, but also we have civic engagement promotores. So it's the whole spectrum of providing direct services and then working with those members, those people that are going to be affected by these, by the cuts that are being proposed. And so I think to share an example, the best way I could do that is to share a story on how that works. So I'll talk about Araceli, who is one of our promotoras, one of our lead civic engagement promotoras. Araceli came into the organization over 20 years ago because she was bringing her kids to a children's initiative, so a health program at the time, a mental health program at the time for children. And she would bring in her 2 sons, and she started seeing how much her kids loved the program, and so she started volunteering. And over time, she was onboarded as one of the promotoras. Araceli always shares how she was very hesitant because she talks about all the things she can't do. She doesn't see herself as this, and I think she does now, but she was this amazing person from the beginning who was already taking a lead in improving the health of herself and her family, right? So we see that as leadership already just by being there. And so she was onboarded as one of our promotoras. She was in the mental health program for a long time, working with other moms on what is the impact, what's happening with our children, how can we have those conversations, what can we do as moms. And eventually Araceli experienced, just like many others in the community, an eviction. She was struggling with housing insecurity, and she brought that to the organization where she was given the space to share what's going on. And we started identifying that she wasn't the only one. So housing was adopted as one of the key issues for the organization. And so Araceli eventually was trained on providing tenant counseling. So those moms that she was already working with, how can she share? What are your rights as tenants? How do we prevent ourselves from being evicted? How can we work together? Fast forward a couple years, and that was what became the first tenants union in the city of Santa Ana. And so that is existing today, the Esperanza Tenants Union, that is working together currently on some of these advocacy efforts in Sacramento, but they were also key in implementing and winning a rent control ordinance in the city of Santa Ana, rent control and just cause eviction protection ordinances, which is a direct policy change. But I tell that story because it started with Araceli volunteering, bringing in her kids. And I want to share, kind of as an example that it takes time to build that power and to grow, but it is doable. And that's kind of the LHA model, how one person experiences this, has the capacity to support the accompaniment to grow as a person, to experience, to participate and learn to be confident in spaces where they've traditionally been excluded from, little by little, and then that replicates with other community members.
Hi, can everyone hear me? Dr. Reyes. So Central City Community Health Center was founded in 1994, about 30 years ago, and we are in 4 counties, LA County, Orange County, San Bernardino, and Riverside. And one of the founders back in 1994 had decided to name Central City because he had a love of comic books. And I don't know if you guys have read The Flash, but in The Flash, hence Central City, was born. And the idea that community health center staff and members are superheroes, that we provide that strength to our community. So Powerbuilding for me, as being a clinician and CEO of an organization, I believe, is in empowering our staff and our patients in giving them the tools and knowledge that they need, not just in our exam rooms, but outside of that. So one of the examples in Community Health Center, you definitely have to have at least 50% of your board members to be consumers themselves. And for us, our advocacy is bringing them out to the NAC Policy and Issues Forum in Washington, D.C., and also Sacramento Day at the Capitol, with efforts and collaborating with coalitions such as this one to speak about their stories. I think storytelling is very impactful, and by letting those elected officials know the stories that they have working on the fields. For us, one of our special populations is the migrant seasonal farm workers. So hearing their stories, hearing their impacts, many of the elected officials love to have stories, not just verbally, but written. So one of my recommendations would be to echo the narratives. Social media is very powerful. In addition to that, I know Dr. Reynosa had mentioned about power building through communities with local hospitals. So another example is having us go to a local hospital, meeting with their leadership, and not just sitting at the table and reflecting an agenda for change, but going into the emergency rooms, actually seeing the patients lined up, not just inside the emergency room, but outside of the ER, and that it's not just the need in the inpatient setting, but what can we do with the work on the outpatient setting to help alleviate that?
Phil Yeager, Radiant Health Centers, and we are commemorating our 40th year of service to the community this year. And for 32 of those years, we operated and were founded as AIDS Services Foundation Orange County. So providing direct care to men, women, and children living in Orange County with HIV and AIDS. So we have a long history of advocacy and power building. I think we can all recall back to the 90s when HIV and AIDS was a disease state that nobody really wanted to talk about, and there was a lot of advocacy work that took place at the federal and state levels. As an organization, we view power building as kind of an internal and an external exercise. Internal, as others have said, we look to our staff, we look to our patients, we look to our board members, we look to those that are directly engaged with us to be part of that effort, part of that advocacy effort. And then looking externally at other organizations in the county and the community that provide like services, who we are normally in competition with, but advocacy provides an opportunity to really collaborate and partner with those organizations. And then taking that even further to organizations like the Coalition of Community Health Centers, where we're not necessarily in competing against each other, but there is certainly opportunity for collaboration. We have state bodies, Equity California, that we joined. There's national movements, AIDS United is another, but really tapping into those local, state, and national bodies that are already doing the work so that we're not having to invent what to do. We join along with them and join their efforts. Something that we as an organization have done recently is we just, I think it was earlier this month, in May, our board approved our next 3-year strategic plan. And I think the high overarching goals, expanding access to healthcare, yeah, right? That's going to be in everyone, right? Financial sustainability, yes. We added a third this year, which is lead social change for healthcare equity. I don't think that would have landed in the top 3 if not for everything that has happened over the last year. But because of it would have wound up as a tactic somewhere in the plan, but not as a major focus for us as an organization. Because those first 2, expanding access to healthcare, financial sustainability, that's not going to happen without efforts on the advocacy level. So that is something that our organization has just recently done, and it's a commitment that we know we've had to make to our community. to continue healthcare. Thank you.
Thank you, Phil, for that one. I want to take it a level down now and really get very specific with this question and kind of draw out a little bit more of maybe the implementation or the activity part of it. And as you all are thinking about some of the examples that you all have implemented over time, what is one specific action organizations and individuals here should take to build lasting power and shape policy decisions at both the local and national level? And I'll start again with Dr. Lee.
Yeah, I've been thinking a lot about this in light of the external environment that we've been experiencing the last several months. We have no control over the external environment. We have no control over the circumstances that are external to any of our organizations. But what we do have control over and what we continue to choose day over day is our mission. And so every day I get up, I think about my mission. Every time I see the people that I lead in my organization get frustrated or scared or angry, I remind them about the mission, because that's the thing that's going to keep us going when the external environment is so hard, right, and difficult and challenging. And so, what does that look like? It doesn't mean ignore what's happening on the outside, but what it does mean is you double down on what you've put into your strategic plan, what you've put into your budget, and you work really hard to achieve those things, because that's where we have hope, right? What's the line from Andor? Rebellions are built on hope, right? And so, I think that's a big piece of that. Let me give you maybe a solid example of what that looks like. Kind of reflecting on my time working closely with the coalition, actually, during the pandemic. Do you all remember that time when, the vaccines are coming, and we all got super excited, and then it got really hard to get the vaccines, and then it felt nearly impossible. So literally, we were going to do an event in Santa Ana at a school, and effectively those vaccines were promised to us because we were going to meet some of the health equity needs. And what I was told on the phone was, well, you have to have someone drop by the healthcare agency between the hours of 2 and 3 on a Friday. Like a super narrow window, right? And so I called around with my staff, and no one was available. And I could have gotten mad. I could have said, well, crap, we're not going to get those vaccines, And so I canceled meetings, and I got in my car, and I drove, and I knocked on the door, and there was a whole process that, in order to release the vaccines to get those done. And then that very next day, I had thousands of dollars of vaccine sitting in my trunk that I needed to get over to the fridge, quickly. And then, by virtue of that, we got 400 doses of vaccines into people the next day. So sometimes when those circumstances put things in your way, it actually forces you to be creative, and also reminds you of why you're doing what you're doing. Because I think it would have been very easy for many of us to just say, well, the world is against us, we give up. But people were relying on us to make this happen. I think the other point that I'll make about that is that we got very efficient at getting vaccines into arms. So every hour we would meet to talk about how we could increase that throughput through the clinic, through the gymnasium at the school. And I think at the beginning we were doing maybe, 25 or 30 per hour because it was just super slow. And by the end, we were getting at 75, 100 per hour that we could kind of get through throughput. And again, it was just focusing on that mission and then focusing on the operational aspects that we could leverage to improve our ability to serve our patients. So I know it's hard right now. Just remember, you didn't choose any of the outside circumstances, but you did choose the mission. And I think that can help you keep going.
Thank you, Dr. Lee. Hilda?
I think it's a tough question to answer. What is one thing we can do? Because I think, at least speaking from the grassroots community organizing perspective, like Dr. Reynoso shared, power building is not easy. It takes time. I think from the institutional or organizational perspective, and Philip also touched on this, I think we need to make it part of our mission. If power building is not a part of our organization's mission and there's specific strategies and we put thought into how we're going to do this as an organization, as an institution, if that's not clear, then it's going to be very difficult to be able to implement. And I say that also because I think the community health worker, the promotor model has been trending recently. And there's a lot of interest in how to engage community health workers, promotores, to start doing some of the power building and start bringing in some of that lived experience into our organizations. And I think that's amazing and that's great. And obviously we work with the promotor model. And I also think that's step one. You know, after we engage them, after they're there, then what are we doing as an organization and institution to really allow those community members or promotores or people with lived experience to share and to propose solutions and to be part of the decision-making tables. And so I would say that that's the biggest thing in terms of institution. How do we analyze what we're doing now? Because I agree, you know, in times of crisis, we went through this during the pandemic, we're in the middle of another crisis. It's an opportunity for us to reset and look at what are we doing? What have we been doing over the past years that has supported or not the improvement of community health. And so really analyzing ourselves and doing some of that internal reflection, I think would be the best, one of the best things to do right now.
Thank you, Hilda. Dr. Reyes.
Thank you, Ryan. I'd say that focusing on the why, you know, why did you show up here today? Why do you do what you do? And in community health, part of our why is servicing an underserved community and understanding what their needs are. So in light of the recent political administrative change, many patients faced, you know, immigration issues and concerns of fear of just coming to our health center. So being able to quickly pivot on policies and procedures, implementing knowledge, growing our leadership and those in the front lines to understanding campaigns surrounding knowing your rights. An example is getting those red cards, and I do have about 200 extra. I definitely would love to pass them out to you guys all, but to give that to patients and staff, understanding what they can do and what rights they have.
So our advocacy efforts have been managed by Director of Communications and Public Relations. Because one of the biggest frustrations I would hear from the staff and from board members is this news and the information they'd get, the threats, the proposed cuts, and so on, and that this immediate anger and wanting to take action. They're like, what can we do? What is there anything we can do, you know, around this? And by providing them with very clear and easy to follow instructions on how to make that call, including use this link to find your elected representative, here's how you find their number, here's the script that you can use. By providing that, it allows people to immediately take action, be successful. They feel a little bit better about having at least done something, done what they could do to have an impact. But organizationally, we've further committed to investing in a new role within the organization to lead government affairs issues. And as you all know, for health centers, to commit resources to a position and a role that's not necessarily generating a billable service is a challenge, but it's something that we feel is incredibly important. Because again, we're not going to achieve our other main objectives if we don't address the advocacy needs. Thank you.
Thank you, Phil. At this point, we're going to open it up for any questions within the audience. So don't be shy.
Thank you, panelists. We needed your input and your encouragement. Did Dr. Reynoso leave? Okay, so can I put that out and tag your it too? So he walked us through these exercises on action planning, and I'm an old lady, so I've been doing this for almost 40 years, and in the day pre-internet, when we wrote letters, when we knocked on doors at district offices, it seemed to be effective because there was a human factor. In the post-internet era, you know, you can send these massive emails, these formatted petitions. I fear that it's losing its impact, so I wanted to hear from people who are doing this currently. Are there tactics that are more efficacious, meaning when we get a coalition of 20, 30 doctors knocking on doors, that's what the CMA does, that's what NEPO and EMOS does. It feels like it's more effective. I don't know. You know, I take a whole day out of my life. I fly to Sacramento. I do this. I get together with my colleagues. It feels great because you're doing something, but does it really make a difference? So if you could give us some tips, because we're sitting here, you know, racking our brains on how to build these coalitions and these campaigns. What is effective, really? Give me the inside scoop. Thank you so much.
Dr. Reynoso, would you like to come up here? I would say that from my own personal experience, having done multiple fly-in days to both DC and with other colleagues on this panel as well, going to DC and Sacramento, one, I still believe it's very important to meet with staff. You can also meet with the congressional leader as well, but a lot of times staff is the individual that needs that knowledge or can share that information. Usually they're considered experts on the topic. I still believe that for me, in my relationship that I have established so far with both district office, local offices, but also in DC and Sacramento, it's still important to make those connections. It's still valuable. I would say one of the great things that Dr. Reyes mentioned is that she, in terms of her building the capacity of our board, she's one of the few of our member organizations that actually takes board members with her to DC to do advocacy work. And I think that she takes the board members, then these are not professional board members, these are also patients. And if they live in that district as we meet with that legislator, staff, and or congressional representative, that means a lot. I will say that it does, as a whole, we go, and there's like several thousand of us that go on these fly-in days specifically, that there is some sort of magnitude with the individuals that we meet with, being that we're all there at the same time advocating for those same things. So the message is very clear, it's concise, and it's very similar to everything that the other colleagues would hear. I will say that custom tailoring your messaging is very, very important, because in some of the conversations that we have with our local electeds, the conversation is different if they're both Democrats versus if they're Republicans. And for much of the time that we have been there, and the most recent fly-in I did earlier or last month, I should say, the conversation with our Democratic representatives was strategy. It's like, this is what we need to do. This is who we need to talk with. When we spoke with our Republican colleagues, it was more about providing that education and those patient stories. So you do have to be very specific about the messaging that you're sharing, one, but secondly, also understand your audience as well. And understand that a lot of times, I would say that regardless of what side of the aisle they sit, they all are common. They're all people. They all sometimes represent or believe in the same values and beliefs that we all do. And to that end, it's also about finding out what these people need. I think in a lot of ways, for them to somewhat stick their neck out is political suicide, and you're starting to see some of that unfold now. I do believe that what I always end my conversations with many of our Republican congressional leaders is How can we help you? How can my organization or the organizations that we represent provide you with cover in communities? And I think that goes a long way. I don't necessarily see them as adversaries. I see them as colleagues, and I see them as individuals that can help us move the needle. Again, we're all decent people. I have to have faith. You can't lose faith. And, I see Dr. Lee, this is something about funny with Dr. Lee. He lives in memes. And so he brings up these little comments and suggestions. And the thing about republics are built on hope. And I definitely do want to say that there are individuals that still believe in that. And you still have to have faith in the system. You still have to have faith in people. And I'll give you one example where we speak to many of our congressional leaders, and some are, oh, it's doom and gloom. It's really, really bad. And you just get this sort of cloudy feeling while you're there. And others are still hopeful. Others are still willing to carry the torch for us. So I still believe, to your comment, Doctor, it is very important to still make those connections. And I would say that I'm on the older side and still probably more focused on, yes, you can send emails. Yes, you can leave messages. Yes, you can send patient stories. I think maybe the medium has changed, but I will say that many of the officers we have talked to, they still receive faxes. And to them to have a stack full of faxes, to me, says something. Because a lot of times when they go and they testify, they will hold up a stack of paper. Now, whether there's anything on those pieces of paper is a whole different story and a different question. But for the most part, either they bring the faxes or they will take printouts of those emails. So I do believe that it still works, and I do believe it's still important to do so. So again, that's my own personal thought on that, and I would invite my other colleagues. And Dr. Reynoso, if you want to come up and sit up here.
Sure. I mean, that was a great answer, Ryan. What I would add to that is all of the tools and tactics, they work, but it's really about the integration of all of these tactics and tools into a strategy. So I'll give an example, with at Latino Coalition for all of California, putting a prior hat on, it wasn't just having our policy advocate go do those one-on-one meetings. And then when we would bring together some of the voices of our coalition members across the state, and we captured these stories, we might put them on a infographic and then share those both on social media, but then we would follow up by printing those stories out and putting and sharing those in person with members of the governor's office or members of the state or assembly. So it's really all of the above. Really what you're trying to do at the end of the day is create an echo chamber. They almost can't ignore your position, what you're trying to say. And when I was at HHS, so putting a different hat on, what was the most helpful from those of us that were, from the government perspective, is when folks would come to us and there was a very clear problem or issue and very specific set of recommendations. So the more focused you can be, oftentimes you may have 5, 10, 15 minutes. So being prepared really matters. So I thank you for taking the time off, especially for those of you where this is not your day job. But I think having diverse voices from the provider community, from the community member perspective, promotores, all of that is necessary, and it's about creating that ecosystem, that environment, and that echo chamber to create meaningful change. So long-winded answer to say yes, keep doing that. Maybe, the 1,000 emails in the inbox for a particular member may not be as impactful. I still think those one-on-one conversations are impactful, but then also follow it up with social media and all the tools that we have at our disposal.
Yeah, I agree. I think a multi-channel approach is the way to go. When I looked at your table, I was like, oh yeah, those are all things that I've seen be done. One of the other hats that I wear is that I'm on the board of directors for the American Academy of Family Physicians, and we talk a lot about reaction versus response, and it's it's very easy to react to things. And I think in the current environment, in some ways, the reaction can sometimes be a distraction, whereas the response tends to be something that is focused and specific and may require a little bit more time, but also can be a lot more heard more effectively by the other person on the other side of the table. And so I think I think there's value in the continuing aspect of going into those fly-in events and that sort of thing. I think there's a lot of work that happens in the interstitial space between those meetings that where we can leverage our policy experts to help us with honing and crafting that message. And I think there's definitely a leadership moment here. Back when I was chief at Venice Family Clinic during 45's tenure, one of the things my boss said to me, she said, Liz Forer, she said, "We can't sit here on the West Coast and feel like victims. Here are all the meetings in DC that just happen to be really close to the Capitol. Get your walking shoes on and get your white coat, let's go." And we didn't really have a plan, but we developed a plan as we went with help and with others along the way. And every time the Affordable Care Act was not defeated, we felt like the Miami Dolphins who were undefeated and raised a little glass of Prosecco or champagne or whatever it was. But I think there's still quite a bit of value in that. And I think the one strength that physicians in particular have, those that do primary care in particular, is we know how to build relationships and we know how to meet people where they're at. And I think that's the superpower that you can bring to those legislative.
There's a famous poet called Rumi who said that you're not a drop in the ocean, but an ocean in the drop. So meaning that I don't want you guys to feel helpless. I think all forms of advocacy are very impactful. And for the students in the room, social media is one of the most powerful ways to impact that. Resharing posts by lawmakers and policymakers. The Prop 35, also, I think they did some marketing around that during the Super Bowl, for example. So really trying to tap into the post-internet phase of getting into social media. But as Ryan mentioned, having those faxes, being able to lift that up in a committee and saying this is what's been impacted, by the community health centers and by the patients themselves have been tremendous. So wanted to just add that. Thanks, Ryan.
Yes, absolutely. Social media is part of this ecosystem, and it does matter. I'm going to answer your question in a different way. I think part of this is how do institutions, organizations create opportunities for youth to be involved? So I think that's part of it. The onus is on those of us that have the ability to do that. Many organizations in my former world, in health advocacy, we started developing youth advisory boards, for example, and engaging youth in the work that we did at our respective organizations. At LCHC, we established under my leadership Health Justice Fellowship, where we took folks at different stages in their educational career, undergrads, grad students, to learn about advocacy and come to Sacramento and participate in one-on-one legislator meetings to be more exposed. I know many, when I was at an undergrad in college, there were organizations, student associations that did their lobby days in Sacramento, primarily around, higher education funding. But, I encourage folks, if you know of organizations doing that, to be involved. Part of it is, as well from the, youth. I would say it's on you also to come together, organize, and connect with one another on issues that you're passionate about. Like I mentioned my time in Ultimed. This was I may look young, but this was a while back. Okay. there was a government affairs department, but it was like one staff, maybe two staff people, and they didn't have a lobby day. So I got together with folks that were part of my Miracle program, but then other kind of allied staff at Ultimate, and we created a lobby day. And I didn't know what I was doing, but we figured it out. And we took something like 30, 40 people from the organization, and we met with CPCA, and we met with elected officials and folks that were part of the administration. We developed it for ourselves, those opportunities for engagement around issues that we cared about. So I think part of it is, to answer your question again, social media matters, and it's organizations should create opportunities for youth to be engaged in advocacy. And I mean, by you all being here today, the students and youth in the room, I mean, you're already engaged, so you're already ahead of the curve.
And then lastly, I want to follow up is that most recently in April, our statewide primary care association, CPCA, held their Day at the Capitol event. We did take a cohort of Prime LC students from UCI School of Medicine with us. So they got to spend time with us as we went, I would say almost 15 people deep into our local legislators. We had about 6 meetings that day with our local electeds, and these students got an opportunity to be part of that conversation with our elected officials. Again, same thing. They got to see what it was like to meet with a Democratic representative, but also with a Republican one, and how the conversation was so much different and how it was structured a bit differently. So I do want to say that we have established relations with many of our medical schools, allied health, PA, pharmacy schools, where we're always looking to figure out how to engage with them, because a lot of this information, or at least this power building, is not taught in academia. You learn this by moving your feet. And how do we institutionalize a lot of this practice in working with these schools to implement that, or to engage in that and understand that that is a priority, that I think from what we've seen so far, that it is something that has value, and that the students find value in that, are willing to spend the time, resources, and also to learn. And we're also willing to kind of also match that with our own resources, time, and education to help bring the next, I would say a next level of leadership with us as we engage in this process. So with that, Dr. Lee, I think you want to say, Hilton, you want to mention something?
I was going to add, I think I agree, all of the above. And I think particularly with youth, or with anyone, nobody likes to be tokenized, right? Nobody likes to be brought on just for one particular agenda. I think that goes all the way around with the staff. I agree, building those relationships in between those asks is so important. I think also working with community and how do we engage them more. It's also understanding that their agenda might be different from ours. And I'll give the example, we work with a group of youth who were brought in together. We have a children and youth engagement department, and they came together because they all liked riding their bikes. And so they came in out around, bike riding was the shared hobby there, but they came and they started talking about riding their bikes and what are the issues with riding our bikes. And there's so many accidents happen, and I know this person got run over because our streets are just not built. We don't have the infrastructure for bike riding. And so what do we do? What can we do about that? That turned into our Santa Ana Active Streets Coalition, who is working with the city of Santa Ana to improve bike infrastructure in the city. And so it's also, it has to be very personal, and the passion has to be there, and it can't be an agenda that's dictated.
Yeah, and what I wanted to share is that I think when I think about sort of like changing the world, which is ultimately kind of what we all want to do to some degree, there's steps to getting there, right? So first step is knowing yourself, understanding who you are. Second step is showing up. And so you guys have done that. You've shown up. The hard part is that third step. It's occupying the ground and getting really good at doing something, and getting really good at using your strength to make a change happen And you know that you're doing it right when people are fighting you, because it gets hard. And when it gets hard, you know that you've hit the right nerve. So, and you don't have to do it alone. There's community that you see around you, and there's community online. So, don't give up. There's still a lot for us to be doing in the world.
Thank you for that. As we close, I just want to thank all of our esteemed panelists and speakers for the day. So can you join me in giving them a round of applause, please? And then I want to follow up or just finish up with a few takeaways that we heard from today's presentation. From Chris's presentation, the fact that we're only halfway through the federal budget process, it sort of helps our argument. Keep talking about Medicaid and SNAP as one item together. Focus on California's Republican members of Congress, which is David Valadao up north, and then also Congresswoman Young Kim here in our own district. And to that point, and to address your question, Mr. Franks, we do have data points that speak specifically to what Dr. Reynoso had mentioned, but also the other tactic we're sort of taking with her is, in places where many of these members might be vulnerable. So for instance, those two members definitely do have re-election campaigns that are in full swing, and they are up for re-election in 2026. Congresswoman Young Kim specifically won by a margin of a few tens of thousands of votes, but the number of individuals that are in her district that are actually on Medicaid numbers around 70,000. So I want her to also understand, and she is fully aware of this, the fact that as people start to roll off Medicaid, she potentially could be losing individuals, or that might be hampered by Medicaid, that she potentially may lose votes moving forward. So we haven't been shy about that comment, and we need to be very, very clear on that, because as you mentioned, there is a sense of a disregard for data or fact or truth, and the truth is what they make of it. And so for us, we have to break it down and make it, this is a real conversation. We definitely do not, Congressman Ken Calvert, also in Southern California, he probably won't be reelected, but he doesn't care. So again, it just also is about knowing your audience, but then also making sure you have the right data. So we actually do have that. So we can definitely connect you with our staff to provide you with that information. We also want to focus on our own state legislators to help them understand the impacts of the cuts. As Chris also mentioned, there is a lot that's coming down on the federal side of the budget that directly impacts California drastically. Again, the work is overwhelming, but we're not done. From Dr. Reynoso's conversation, really have to go upstream to have a population health effect, focus on policy and systems change in order to address root causes and health inequities, consider creating strategic partnerships with organizations or initiatives that focus on power building. The one thing I also wanted to add is that you mentioned that policy change takes a long time, and I'm even going to predate some of the work that you had mentioned about Health for All. I was actually with the Californian down that time and helped manage the portfolio of covered California kids, which provided health insurance to tens of thousands of undocumented children back in 2006. So again, policy change can take 20, sometimes 30 years, but the impact of what we do at the end of the day is what you have to think about and look forward to, and can't be discouraged. Takeaways from our panel, Dr. Lee talked about co-opetition, working together with a spirit of competition and coordination to further goals. He also talked about we have no control over the external. What we do have control over is our mission. Hilda talked about we need to make power building as part of our institutionalization within our organization and our mission. Dr. Reyes has one of the great comments of focusing on our why. And that's something that we also ask, what is your why? Why did you show up today? And why do you do what you do? Philip had a great strategic or a more of a capacity issue that he addressed, and that was to invest in communications, policy advocacy. As a health center, these are non-funded positions, meaning there is no reimbursable line item that will get you to support that staff position. But again, it is something that is very, very much ingrained within the organization, as well as important to the future of the organization. And then lastly, Dr. Lee followed up with, the multi-channel approach, Reaction versus response, I think, is a great comment. And then lastly, one of the things that Dr. Lee said earlier was, I'm a doctor and I know some policy stuff. So with that, I want to thank you again for staying late with this. Thank you all for your participation, your dedication to today's, and your commitment to creating a better future. We look forward to seeing you at our next Coffee Connections event, which will be on Friday, September 12th. So safe travels, and thank you for joining us for the day.